Welcome, everybody, to Advancing Personalized Medicine Through Inclusive Biomedical Research, a PMC seminar on a critical topic. We have learned a lot from COVID about healthcare in the United States, some of it good, most of it bad and ugly. And very high on the list of bad and ugly is how COVID has disproportionately impacted minority communities for reasons that are both known and unknown, suggesting that our healthcare environment is less inclusive and more unequal than anyone considers acceptable. Like many, if not most healthcare organizations, the Personalized Medicine Coalition has been considering how we can contribute to reducing the size and scope of those inequities, which threaten all of our goals. It is our contention, given PMC's unique focus, that we can, through the lens of personalized medicine, which after all is premised on understanding that people are different and therefore need targeted health solutions for their particular needs, provide a new framework to understand both the challenges and the solutions to the problem. That problem can be defined as nothing less than building a more equitable, inclusive, and accessible healthcare system that serves everyone. That is the purpose of our seminar this morning. And I hasten to add that this is not a one and done exercise. We are convening here now to learn how PMC can contribute to the goal I just outlined. We will be listening closely to our panelists this morning regarding what we need to do to reform the research enterprise and to build a more diverse workforce, as well as to our members over the coming weeks. PMC is committed to launching a research project / white paper that will, again, through the lens of personalized medicine, contribute to helping address these issues. So with that as an introduction, I am pleased and proud to introduce Jeff Ginsberg as our moderator. He's agreed to help us negotiate this difficult terrain and to guide us safely, I hope, towards our goal in the next 85 minutes. Present at the creation of the Personalized Medicine Coalition, having served on its first board, Jeff is also the founding director for the Duke Center of Applied Genomics and Precision Medicine, a position he holds today. In addition, he has co-authored the standard text for the field, a professor of medicine, pathology, and biomedical engineering at Duke. He clearly has an interest in getting the subject of today's discussion right. So with that, Jeff, I turn over the Zoom to you.
Hey, thank you, Ed. Thanks for introducing me and also for introducing this important topic to the Personalized Coalition, as well as for hosting this event. I noted that this week, the Personalized Medicine Coalition newsletter had a piece by Chris Wells, who's the Vice President of Public Affairs, in which he said, quote, "There is a renewed emphasis on addressing systemic inequities, underlying the importance of correcting a lack of diversity among participants in clinical trials for new drugs and vaccines, which leaves patients from underrepresented populations with unanswered questions about how new interventions may work for them. When it comes to personalized medicine, this is a scientific necessity as well as a moral imperative," unquote. So today we have two sessions to address the topic of diversity in personalized medicine. In the first, we will discuss inclusive biomedical research to promote personalized medicine. And in the second, we will discuss how to access personalized medicine services and technologies by underrepresented populations, as well as enhancing the personalized medicine workforce. As Ed said, one of the overarching goals of this seminar is to help the PMC develop its action plan in these vitally important areas. And needless to say, we expect there'll be overlapping themes that emerge from both of these sessions. So I may press our panelists from time to time to get very specific about the actions we might take coming out of this discussion today. So for the first session on inclusive biomedical research, we have four amazing panelists. Bonham, who is the Senior Advisor on Genomics and Health Disparities at the National Human Genome Research Institute. Gregory Calip, who is the Quantitative Sciences Head for Medical Affairs and Scientific Affairs at Flatiron Health, Jane Delgado, who is President and CEO of the National Alliance for Hispanic Health, and Michael Sherman, who is Executive Vice President, Chief Medical Officer for Harvard Pilgrim Health and Tufts Health. I would like to invite each of the panelists to turn on their cameras, and I'm going to ask them to start off this session by introducing the lens that they bring to this topic and make a brief statement on inclusive biomedical research. We'll then move to a discussion, and I encourage panelists to ask questions of one another, as well as make this as interactive and as lively as possible. So let's start off with Vince Bonham.
Thank you, Jeff, and thank you for this invitation to participate in this important panel today and the important work that PMC is doing. So I'm coming from the National Human Genome Research Institute at the National Institutes of Health as the senior advisor to the director of our Institute for Genomics and Health Disparities, and helping to guide and lead our work with regards to issues of health equity and diversity within both the ancestral populations that are studied in genetic and genomics research, but also in the workforce. So what I want to make in my brief opening comments is to talk about some of the work that the National Human Genome Research Institute is taking on. That's really framed around a strategic plan that we published in October of 2020, which is the strategic vision for improving human health at the forefront of genomics. I want to highlight one of the goals and values that we identified in this strategic plan, which is the goal and value to strive for global diversity in all aspects of genomics research, committing to the systemic inclusion of ancestrally diverse and underrepresented individuals in major genomic studies, which includes meaningful, sustained partnerships with diverse communities. And I want to just highlight that: meaningful, sustained partnerships with diverse communities in the design and implementation of research studies. So the work of the Institute, the work of NIH, and hopefully partnerships with the members of the PMC is how can we do that better? How can we engage and move forward with regards to working with communities around the research that's being conducted around personalized medicine and precision medicine to move forward? The second area that I want to just highlight is also from our strategic plan is that we must have a much more diverse workforce for the field of biomedical research, for personalized medicine, for genomic medicine. So we must have a diverse workforce conducting research. The promise of genomics, and I would argue also personalized medicine, cannot be fully achieved without attracting and developing and retaining a diverse workforce, which includes individuals from groups that are currently underrepresented in the biomedical research enterprise. So those are my comments to start us in thinking about it. We're really excited from the National Human Genome Research Institute to be part of this conversation today.
Thank you, Vince, for bringing up the two major points of sustained meaningful partnerships, as well as a diverse workforce. And I think now we'll move to Gregory Caleb for his opening.
Good morning, everyone. Thank you for that introduction, and thank you to PMC for inviting me to join these esteemed panelists today. I'm really excited to be here. As mentioned, I'm the quantitative sciences head for medical and scientific affairs at Flatiron Health. I'm a cancer epidemiologist and health disparities researcher. And as an epidemiologist at Flatiron, I essentially spend most of my time making sure we get the data right, and then letting that evidence-based guide decision-making about cancer care. And what the data that we have on cancer disparities currently tells us is that there are disparities in treatments and outcomes among cancer patients where we live, our race, ethnicity, and social determinants of health matter. But that's really only part of the story. Lack of inclusion and being underrepresented in biomedical research can obscure or even deepen these health disparities. And as leaders in health technology and personalized medicine, we can either help close those gaps or make them bigger. So I joined Flatiron Health, where our mission is to learn from the experience of every cancer patient, and we do so by leveraging health technology and electronic health record data, or EHR data. I think about our approach to inclusive biomedical research in two ways. The first is data equity, the importance of being counted and having the opportunity to learn from patients that aren't always counted or are underrepresented in clinical trials. The second and last point I'll make is perhaps the bigger challenge that I hope we discuss today is utilizing EHR data and other health technology through a health equity lens. So going forward and with intention, thinking about how personalized medicine and new technology, for example, how we can match patients to clinical trials using technology or AI, or either lower the barriers to participating in biomedical research and advancements in healthcare, whether they could lower those barriers or perhaps even perpetuate the existing structural challenges that tend to leave underrepresented communities behind. I'm glad to have this opportunity with PMC to talk about those today.
Thank you, Gregory. I think we really look forward to engaging with you in a discussion about closing the gaps in inclusive research so that the data bases at Flatiron and other are not inherently biased, which I'm sure is an issue you're addressing head on. So let's move on now to Jane Delgado.
Good morning, everybody. Thank PMC for pulling this panel together. I also want to thank everyone who is listening to us because you're the people who care about these issues. For me, I'm the president and CEO of the National Alliance for Hispanic Health, and we've been working on tailoring treatment to the community for a long time. I'm also vice chair of the Lovelace Biomedical Research Institute, the largest freestanding research institute in the country. And there we do a lot of the basic research that brings us to the medicines and treatments that we use today. I understand that a lot of people like to say, well, we need to build trust in the community and we need to do all this work. And yes, that's important. But I also think that the research community needs to take a step back and ask themselves if they are asking the correct questions and on what data are those questions based. Because in fact, one of the things that we know is while the 20th century had its lovely aspects, a major problem was that we aggregated data and future studies were built on that past aggregated data rather than saying, what do we know now about people? And what COVID did, it showed us that as we learned more about people, what we thought in the beginning was wrong, and we had to rethink what we were doing. That's not just for COVID. That goes across the whole science enterprise, from what we know about infant mortality, to what we know about hypertension, to what we know about care. So at the Alliance, our motto is science-based and community-driven. And that's the voice that I want to share with you today.
Thank you. And I think the subtext to what you're saying is that without the participation of diverse communities, we really don't have good science. I think that's at least that's my interpretation, and look forward to bringing that into the main discussion in a few moments. Michael Sherman.
Yes, hi. Good morning, and it's a pleasure to be here virtually with all of you today. I represent the payer community, specifically two organizations that actually merged together in January, Harvard Pilgrim Healthcare and Tufts Health Plan. And together we serve almost 2.4 million members, but interestingly, about 300,000 of those would be classified as diverse. If you think about what health plans do and how they impact the care that individuals receive, we don't replace a physician, but we do impact the services and care that people get. For example, we develop policies that determine what's paid for and under what circumstances. We have care managers and other staff who reach out and provide support. And we have various initiatives that are designed such as to influence, such as offering precision medicine diagnostics and others to the community. And in developing the policies that determine who gets what, we're dependent on data. We don't make up data at health plans. We depend on outside sources from all over the world. And to the extent that that data is not broad, that it doesn't not represent all the members that we serve. It means that we're doing a less than stellar job in providing personalized care for each of our members. I'll also note, because this came up in the introduction, that we have algorithms that help us identify members for outreach. Well, we've learned, as has the rest of the world over recent months and years, that some of this may be biased, not purposefully, not consciously, but based on the inputs and the way that these algorithms were derived, that they may not be providing the kind of information that allows us to support all of our members. So we're glad to be here in this discussion, and this is something that is very important to us as an organization if we're going to be successful.
Thank you, Michael, for that, and also again reemphasizing the biases that might exist in data structures that lead to algorithms that lead to disproportionate ways of accessing and giving care. We'll come back to that, I know, in a few moments. So let's open up this panel with the first topic that has come up in some of your opening remarks, and that is one of trust. Trust of the participants with for the research community. And I wonder if this group could tell us, how do you see the relationship currently between participants from underrepresented populations and the research community, and how do we engage the research participants to develop trust that is necessary for their engagement, and then downstream to provide their data and other types of information that are going to more equitable representation in the research databases and the like. Could you, any of you wish to start off on the concept of trust, and how do we build that?
So
I
I'll
think it's
start.
fair to say that. Okay.
No, go ahead, Dr. Delgado.
I was going to say, I can say that at this time, trust in the science community is not at a high point across the board. And in our communities, even more so. When you have been left out and all of a sudden people want to study you, you sort of don't understand or trust their motives. And, you know, too often what people do is helicopter science. They drop into communities, they do something and they leave. And people don't want that. They want to know what's going on. They want to be a part of it. And also, you can't expect people to participate in science if they're not getting their basic healthcare needs met. So I think it's not only up to the communities. You know, a lot of people say, well, you know, the communities have to be more trusting. Well, the people going in there have to earn that trust over time. It doesn't just happen all at once. You know, very often when people are hired to work in communities, they're practically like bodyguards because other people don't know how to enter communities. So it's a long-term process. And I don't think people want to invest that. They want to get their data and get out. But that's not where communities are at. No community, whether they are underserved communities or majority communities that have been served very well.
I agree that trust is not at a high point. I'd echo that. And unfortunately, we're seeing it now with rates of vaccine hesitancy that are higher in various communities that are less trustful. And, you know, what can we do about that? Well, one suggestion, again, it's not an immediate fix, having researchers, having organizations that look more like the people they serve. I mean, you know, we can talk about having diverse workforces as, you know, as objectives and initiatives, but we sometimes forget the reason they're important is we're going to best connect with the individuals who are trying to support if we look like them, if we feel like them, if they sense some commonalities. And, you know, even some examples as a pair, we've had some examples where we know that our care managers have reached out sometimes to, for example, to an individual who's prison guard and African-American, and after getting her first shot, heard some things about various research studies in the past from friends, and they made her distrustful, not wanting to get a second one. And we had someone, again, to your point about dropping in and out, there was a care manager who she had a long-term relationship with, who, after a couple of calls and discussions and examples of others who've gotten vaccines, convinced her to go ahead with that. So yeah, it's about having more diverse workforces that are inclusive and having those long-term relationships, which is very, very tough in a research setting.
One thing I would want to add to the two comments that were made that I totally agree with is that there is clear evidence that racial and ethnic minority communities, underrepresented communities in biomedical research are willing to participate in research. It's not that communities do not want to participate in research. It's the question of how they're accessed. How are they reached out to? Is it with respect? Is it in an intentional way to bring the communities in and individuals in? So I think we need to always remember that this is not an issue where the communities just fear research and I don't want to be involved, but a question of how do you reach out appropriately to communities with respect. And so this issue of the trustworthiness of the researcher is so important to this conversation of really building the bridge with communities with regards to their participation in biomedical research.
Thanks,
And
Greg. Do you
with
want to make a
COVID
comment?
vaccines- Oops, I was going to say with COVID vaccines, we fund a lot of agencies to go out, and we found that although there's a lot of public affairs about vaccine hesitancy, and the people who have vaccine hesitancy have always had it, not just for COVID, but for flu and a whole host of other things. What's missing is logistics hesitancy, because a lot of people are working in jobs where they can't go when they're doing the vaccines and they need to work. So it's like there are problems in getting that. And the idea of two shots for some people means losing 2 days of work. So I think that part of it is that how we frame things has to be from the viewpoint of the person that is being served and not from our viewpoint. So I think it's very complex. People want one answer for all. It's not. And that's why personalized medicine is the answer, because it really meets the person where they're at.
It also starts with the choice of principal investigators. So, frequently we're asked as payers, what kind of data would you like to see? And they talk high level about how many members and maybe ages and others, but we don't frequently see plans for clinical trials that explicitly have targets of having a diverse population included. And again, executing on that, it's not just about having that in the plan, but it means actually choosing clinical trial sites that themselves serve diverse members. So it really requires think about this across the entire continuum.
I really
Greg,
agree with my fellow panelists about some of the ways that we kind of engage these communities, and entirely agree. I think that patients, like other people in our country right now, are pretty savvy about what their data represents and what that means, including their health data and their protected health information. And I think if we see health technology and these innovations and advancements as ways for people to participate the way that they would in civic life, participating in biomedical research as a way of kind of being counted and being represented, I think that's a powerful way. One way we can try to communicate that with folks that tend to be underrepresented in our research.
So thank you. One of the things I'm taking home from this conversation is, and I'd like your reaction to this. So one is that we need to really engage our communities up front, and there are a number of research studies that have participant advisory boards and engagement groups that help the researchers actually design studies from the beginning up front, rather than presuming, I think, as Jane said, making presumptions of what the community understands and knows. And the other piece, which you may have touched on a little bit, is what is the community going to get back out of this? It should be a two-way street. Participants giving of themselves and their data, but also should receive something in return that is going to potentially be of value to them. Do those concepts make sense?
I think that that's an important first step, but I think you also have to make sure the researchers are asking the right questions and that the questions aren't biased by the existing knowledge base. And I think that is very tough for people to do because research gets narrower and narrower and more focused, where now that we have more information about different communities, you need to sometimes go back to the beginning and say, maybe I was asking the wrong question. So that's one thing. So it's not just on the community. Communities will participate. There's lots of evidence. Dr. Bonham spoke about that, showing that communities will participate if you reach them the right way. It's like people say these communities are hard to reach. When people want to sell cigarettes or bad stuff to communities, they know how to do it. And I think that because they're there in the community, they have their spokespeople and stuff like that. We in the health field have to take a more proactive, inclusive route when it comes to reaching people. It's not about, diversity, equity, inclusion being what people are talking about today. It's about good science and how we all move forward.
Yeah, so let me follow. I think it's a really important point. And how do we change fundamentally some of the research questions that we're asking, which in my mind begs the question of how does the research community itself understand its own biases and the culture that and the bias that might exist within the investigator groups? What is the best way for us to look at ourselves and understand our biases in everyday research? And is there a research agenda? Maybe this is something that the NHGRI is pursuing, but is there a research agenda that is targeting, the research community, the investigator community, so that they can ask the right questions, as Jane said, and begin to do better science? Vince, do you want to make a comment on that?
Yeah, I'll make a comment. NIH generally is really taking on this question of looking at bias within biomedical research and structural racism, and what we can do as a research enterprise to really be much more introspective about what are some of our failures and how can we move forward in a way that's much more inclusive. And so a recognition that this is an important area for all areas of biomedical research to be involved in thinking about how we ask questions, who's involved, what are the issues that create some of the harms in our work with communities. And so now's the time to really to grapple with this issue, with all the things that are happening in our society, to recognize our own challenges that we have as a field. But I think it's also really an exciting time. And that's why I think this panel and this work of a recognition that we must make shifts. We must have a much more integrated, inclusive, diverse, both populations in the studies, but the people doing the work. And so I think those together are clearly areas that NIH has identified as extremely important.
One additional observation. So if you actually look at my wallpaper that I'm using as a background virtually, it actually refers to our institute, which wasn't part of my introduction, but we do have an institute which within it sits the Department of Population Medicine at Harvard Medical School, and it does a lot of important research, including looking at some of our precision medicine initiatives. And one of the things that they've done explicitly, so it's not by accident, they've explicitly made this a topic that we're talking about as an organization, as a department, having additional training, having additional dialogues about all aspects, and ensuring that any research initiative explicitly asks about the makeup racially of the participants to ensure that it's broadly applicable. So I think actually having it not be something that is an afterthought, but part of what we discuss, just like we discuss what the plan is for accessing an IRB or other aspects, budget, et cetera. It needs to be part of the base discussion.
Greg, do you want to also comment on how a company like Flatiron is moving forward with these issues?
Sure. I really appreciate this kind of question that's about some bias that we can find in our data, especially real world data, because with Flatiron being a cancer tech company, it's a provocative one. And the use of real world data, especially in COVID, is for health decision making is becoming more and more important. So whether real world data comes from places like EHR or from health insurance claims data, for example, there are barriers that exist there too to being included or being observed by taking data that we have from the point of care or from claims data from payers. We're assuming that folks can access routine care or specialist care in the first place. And then of course, there's all kinds of things in real world data we have trouble measuring, like social determinants of health, which we know even has an impact on evidence that we derive from our clinical trials too. One thing that we observed in the last year was this considerable uptake of telemedicine among patients that were in our Flatiron data. And this represented really just this amazing public health response by oncologists to minimize risk to their patients. But then if the uptake of telemedicine fails to deliver across all patients, then really the existing disparities could really only be widened. And what might the answer be to this? I mean, I think that's for all of us to kind of comment and share on, but perhaps shoring up our health technology infrastructure alongside other innovations happening in biomedical research and pharmaceutical sciences. I think that's these all partner hand in hand, and personalized medicine is really kind of the crux of that.
And just to go along with this theme of cancer, I'll give you an example, because I think people have to realize that when you don't do the right medicine for the person, it hurts them. So the American Cancer Society came out with new guidelines this past summer for cervical cancer in women. Their guidelines are, what people look at. But at the very end, under the limitations, they say, we understand that Black, Hispanic, and low-income women are more likely to get cervical cancer, and that the randomly controlled trials do not adequately represent them. So they made recommendations knowing that and those women represent over half of all women when you add them all together, poor, Hispanic, and Black women all together, they still made recommendations that will end up hurting the very people who are more likely to get this condition because we didn't have the right data and information. So part of it is we are very eager to make pronouncements, and we have to be less eager to do that. Also, like Dr. Caleb said, we should not say, is it social determinants of health or is it biology? It's both. And we need to look at a person looking at multiple factors. I know that research design is like looking at one or two things and assuming everything else is equal, but everything else is not equal. And I think we have to be more cognizant of that and take responsibility for what we say and do.
So let me follow up on that, maybe for the panel. It seems like, and this may be a question that's somewhat in the weeds, but when it comes to capturing data, we generally ask participants to self-identify as a particular ethnic group, religious group, sex, etc. So I guess my question is really about what going forward, what's ideal for us in terms of the kind of way we collect data, in terms of social constructs, in terms of molecular ancestry, both, or something else? I mean, how are we going to achieve the ideal state, Jane, that you're talking about in terms of having adequate data if we don't currently have any standards by which to really understand who's in our research studies?
I think that we have to be responsible and get good data. And when we get data that we don't understand, not just throw it out. And two examples that I can give you is that since the early 80s, we have known that for African-American women, regardless of income, they had higher rates of infant mortality. All right, so we needed to start looking at that more seriously. Since the early 90s and late 90s, we knew that if you were Hispanic or African-American, you were less likely to get a painkiller if you had a broken leg. And that was looking, at existing data and looking at the records. But very often when our data doesn't fit the model, we throw it out. And I think that personalized medicine gives us the idea to think there's not going to be one model. each person has their own model. And now we have the technology and the computer capacity, especially in Chicago with the quantum network. Who knows when that'll be, but that'll also change things. You know, we have the possibilities to really do personalized medicine.
The timing is right now, and this does frame exactly around personalized medicine to collect all types of data. We need data with regards to individual social identity. Race and ethnicity data, other social identity data that's important to the social context of the individuals and where they live and their life experiences. But we also have to be very careful not to create that social data as being biological, and be very careful in how we use those descriptors when we are talking about genetic variation or biological variation. And so we also need genetic ancestry data. So we need it all, and we need to capture it all. And I think one of the challenges, but it's an opportunity, is how we harmonize, and how we harmonize as we do global studies, and how we look across populations, and how do we even harmonize within our own country. And so I think this is an opportunity that we have today now, is to move beyond our, crude use of racial and ethnic categories to a much more complex understanding of the social identity and the genetic ancestry of individuals who participate in research studies.
So, who owns this area? I mean, I think everybody would agree with what Jane and Vince just said, but where's the epicenter that is going to begin to create the data standards and access and harmonization that are necessary? Is it PMC?
It's PMC and all the people who are watching us and all of their friends who support these efforts. You know, this is a shift for science to think of really looking at the individual and looking at the host of factors that person presents, and how that enriches us. You know, people always think, well, if you do that, you're taking away from something else. Well, we were doing the wrong thing before. Well, good for us if we're going to be doing something different.
Yeah, I don't know who creates the standards, but I know that we have the right voices here at the table. Generally, my experience, though, is that the 800-pound gorilla is, our governmental programs like Medicare. So if they start demanding that, for let's say for requests to pay for therapeutics or for tests, that the data is put together a certain way, has certain characteristics, and looks at certain subpopulations, that I think would provide the most impetus. That said, we're here participating from different parts of the healthcare ecosystem, and we should all be demanding this. We should be, my organization is payers, similar to what I proposed from CMS, but we should all be doing that. Patient advocacy groups, et cetera. And I do think that PMC is an important voice here, as it has always been around personalized and precision medicine. So the fact that they have the attention of the broader community, that they sit in the center, not as an advocate for any one portion, manufacturers or others, but as an entity which is known for doing the right thing, and has relationships across across the environment, ranging from those of us here to Capitol Hill. I think that is a great organization to be a loud voice and pulling together the various stakeholders.
So that's a great segue, Michael, to I think perhaps the last part of today's discussion is to really help the PMC develop an action plan. And that was sort of a commitment I made to Ed Abrams when he asked me to help with this workshop. So may I ask each of you, you just started the conversation with the convening power of the PMC to bring the stakeholder community together, and also with their role on the Hill, and to influence maybe some policies at the federal level. maybe we can go around to each of you and to give PMC its marching orders in the area based on the discussion we've just had. So Michael, do you want to maybe start or elaborate a little bit on your last few comments, and we can just go around the panel?
Yeah. Again, I think, as I said, it's all of us. I think demanding more, and and even putting together more in a business case here. So again, this is not just about a soft discussion of doing the right thing, but we care as a country about things like healthcare costs, and it is so true that whether it is based on genes or race or other characteristics, that when you are pursuing a trial and error approach, I mean, we're doing some pilots now around pharmacogenomics, which involve paying for pharmacogenomic tests and seeing if they can lead to faster treatment of things like depression, other behavioral health disorders, which we spend a lot of money about that. People are suffering. There's a question whether there's clinical utility, whether they make a difference. Yet, if very likely they do make a difference, and not just again because we want people treated better, which is the right thing from a quality lens, but we waste a lot of money where people get the wrong treatment that isn't right for them because we don't have the data. So I think it's all of us understanding that business case, and I think it's something that policymakers can react to very, very clearly. We also need to again demand more of those who are creating things like algorithms. We actually had a ethics advisory group at my organization involving internal and external stakeholders talking about to what extent algorithms we use to identify individuals for outreach are racially biased, because in some cases, for example, they look at things like utilization of healthcare resources. So if you are part of a group that doesn't have that degree of access to resources, and you're not getting certain types of care, not because you're healthy, but because you didn't have proportionate access, it's going to skew the results and impact who gets that additional support. So again, things like having that dialogue, and again, all of us as users of those, so we're customers of the companies creating those, we need to go back, call that out, and demand that they do better. So I think that there are a lot of actions that we can take from our various vantage points here.
Thank you, Michael. Jane?
Well, I think we have an opportunity now, and the opportunity is to look at some successful models. And I think for us, the NIH All of Us initiative has been a model where they've really worked to include as many different representative people as possible. But they've done two things. Not only have they worked to do that, but they've also listened. And we're very involved with All of Us. And I can tell you with other federal agencies, when we tell them, look, you can't do this way, they have not wanted to listen. They said, no, it's either our way or the highway. And frankly, sometimes we say, okay, we'll take the highway, bye. But NIH has been very responsive. And I think at least the All of Us team is trying. That's a good model. And it's because it's looking at the future, and that you need to have all the social determinants of health information. You need to have biology, microbiome. You need all of that to know the whole person.
Thank you, Jane. Greg?
Thank you. I love following Dr. Delgado's comment on the All of Us research program. I think it's such an interesting model. And as I was thinking about it prior to this panel, I really wanted to think about what would be the, like industry equivalent of that, or how could the response be similar? How could that model be followed? And I think this really wholesome look at different data and patients' data and participation is really one way. Why can't we, utilize data from folks that are seeing out community providers, and also linking to genetic data if it's available, and claims and third-party payer data, and still kind of use technology to respect patients' privacy. I think it's a big challenge. I think finding the middle ground there is key, but something that can be achieved. So I love this conversation by panelists today, kind of bringing all of those data together and looking at the entire patient.
Thank you. Vince, you have the last six.
So really just supporting all the comments that have been made by my other panelists. I think that the PMC is in a position to bring together its members, industry, academic institutions, research institutions, and working with government agencies, NIH and other government agencies to really move this forward. But the message I would like to share is to make sure that you're also bringing those grassroots communities from the diversity of our country. And I think that's part of the success in the All of Us recruitment has been the work with local communities across the country. And so I think engagement in the conversations of those communities, along with the leaders from the various types of organizations, is an important part of the process of really moving and advancing this important area of research.
Wow, thank you all. This was a fantastic discussion, really packed with an amazing number of ideas and insights from all of you. I'm not going to do any just in a minute to summarize, but I want to channel Vince's statement that the time is now, and that the idea that I think I heard from all of you is that we have an opportunity to capture data from all types of sources to really represent the individual, to allow them to be actively participating in personalized medicine research and to access the benefits of personalized medicine in the clinic. And that to do so, a few things need to happen. One is that the lens of the way the research community views research probably needs to change to be more inclusive. We need to build meaningful partnerships with the community, particularly the rural and underserved communities, and use maybe the All of Us research program as a model. And that in doing so, we will build the trust that is necessary, avoid, I think, what people helicopter science, and really unleash the power of individuals to help achieve the success vision of personalized medicine. So I hope those points. And one last thing I think I heard you say is that the convening power of the PMC is enormous and really can help bring the diverse stakeholder communities, including the participant community, together to really make this happen. So I hope I've done some justice in summarizing what you all have said over the last 45 minutes or so. And I want to thank all of you for participating. Vince, Greg, Jane, and Michael, you're fantastic panelists, and I really have learned a lot from you, and I'm sure our audience has as well. With that, I'm going to call this first session of today's discussion to a close, and invite you all to remain with us, even if your videos are off, to listen to the next part of today's workshop. So we're going to transition now to the second session, which is around accessing personalized medicine services and technologies by underrepresented population and enhancing the diversity of the personalized medicine workforce, which is clearly something that was mentioned several times in the first session. So I would like to invite to the Zoom stage again 4 equally amazing panelists. Eli Adachi, who is professor and former dean of medicine and biological sciences at Brown University. Christopher Boone, who is vice president, global head of health economics and outcomes research at AbbVie. Richard Knight, who's president of the American Association of Kidney Patients. And Candace Nordley, who's executive director, diversity, equity, and inclusion at Sloan Partners. Welcome to all of you. And thanks for being here. As we did in the last session, I'd really love to have each of you again introduce yourselves and the lens on this issue of access and diversity of workforce that you will bring, and maybe make a short opening statement on some of the main issues that you see that the PMC and this community can address. So with that, I'm going to start with Eli Adachi.
Thank you, Jeff, and especially for the opportunity to contribute to what is an ongoing challenge and clearly still in need of redress. coming as I do from the medical education perspective, it is impossible to miss the point. Diversity both in medical schools and as a result in the health workforce is clearly not all that it can be and needs to be. We have recently completed a major survey, which I cannot share in detail with you because that work is in press with the New England Journal of Medicine. It will see press later this month, wherein we reviewed the diversity record of all US-based medical schools, of which there are currently 150, over the last 40 years, looking at applicants, matriculants, and breaking down all these metrics by gender, by race and ethnicity. And so we have a relatively broad view of, I think, the circumstances now and historically as they lead us to the present day. And hopefully in the discussion that will follow, although I cannot specifically address myself to the paper, which is under embargo, I'm listing this only to mention the fact that we have recently visited the issue in a very careful and thorough fashion. And so hopefully I am in a position to make some contribution to the conversation today with that backdrop in mind. So with that, perhaps, Jeff, I should allow you to move on to the next panelist.
Okay, but we're probably going to come back and ask you some pointed questions about your findings. Hopefully you'll be able to give us some insights. Christopher.
Good morning, and thank you to the PMC and Jeffrey for the opportunity to really be here. As you stated in your opening, my name is Chris Boone, and I'm the Vice President and Global Head of Health Economics and Outcomes Research at AbbVie, which is, for those of you who may not know, a biopharmaceutical company based here in the US. You know, one of the questions I always get often is what exactly is health economics and outcomes research, and what do we do? And I think the short answer I would respond to that is that we are particularly focused on generating evidence that really demonstrates the clinical, economic, and humanistic value of our drugs and therapies in a real world context. The primary focus there is to really complement the evidence that's generated from the randomized clinical trial in order to, for all intents and purposes, accelerate the access to treatments for many of our patients by providing additional evidence to decision makers. But one of the things I want to highlight today, and I can say to some degree with some level of pride, is the role that AbbVie has taken as it pertains to this issue around equity, equality, diversity, and inclusion. And I would really break it down into four very pivotal areas, if you will. The first being is that obviously you have many companies that have committed themselves to contributing monetary resources for many of these causes. AbbVie is no exception. I mean, last year alone, we donated more than $50 million to support many of our community-based organizations that are focused on health and education opportunities, specifically in Black communities and other underserved areas. I think the second thing is that the company, as you would expect, has committed itself to addressing this issue of reducing health disparities, obviously by developing therapies in areas that are probably a bit more prevalent, certainly in Black communities and other underserved communities. Obviously, you know, in the last panel, I enjoyed listening to him because really this issue around diversity in clinical trials is certainly something that we've been particularly active in, and I can take a lot of pride in because we've taken a data-driven approach, and my group has certainly been spearheading that quite a bit utilizing big data or real world data, real world evidence assets to guide much of our thinking around that, which we can talk about in a little bit. But lastly, I think what the purpose of this particular panel is really around this issue of talent management, and you know, and that's a tricky thing, right? I mean, because for us, it's really been around how do you address the issues of representation, which is one aspect to it. The issue around development of that talent, because not only do you recruit, but you have to retain and hopefully see these individuals progress. How do we create sort of training mechanism, which is one challenge that I face particularly in my area as we think about this supply or pipeline of talent that ultimately will come in, you know, at much more junior levels and hopefully progress to senior levels in the organization. But one thing that you'll find particularly interesting that AbbVie has done that you're starting to see more of is not only are we seeking to address the issue of representation within our walls, but also with the organizations that we touch, meaning that many of our vendor partners that are actually doing business with us, can they reflect the goals and priorities of AbbVie within their workforce as well? Now, that doesn't mean that we could dictate to companies on how they should address the issue of diversity and representation, but it does mean that if you want to do business with AbbVie, then you should probably reflect the client that you're serving. And so, you know, I think that as we get into this discussion today, I hope that we can certainly double click on many of these issues. I'm excited to be here, so thank you for the opportunity.
Thank you, Christopher. That was great. Next, Richard Knight.
Thank you, Jeff. And I want to thank PMC and yourself for having me speak here today. It's truly an honor, both as a kidney patient and as president of the American Association of Kidney Patients. A little about myself, so I want to share the lens through which I will address many of the questions and concerns today that we will be discussing. I spent 2 years on dialysis, and I'm currently 14 years out on my transplant. Unfortunately, I crashed into dialysis to the emergency room while I was under the care of a primary care physician. I'm currently a lecturer at Bowie State University, where I teach business courses in the College of Business, focusing primarily on the area of strategic management and industry analysis. As president of AAKP, which is the oldest and largest independent patient-led kidney group in the United States, I'm privileged to work with thousands of patients in the United States, and recently, thanks to our global initiatives, now worldwide. So we are here today to talk about advancing personalized medicine through inclusive biomedical research. What does that mean for patients? In short, the right treatment for the right patient and the right dose at the right time. So in addressing some of the issues that we're going to be covering today, I want to encourage, and I hope among the audience that we have some patients out there, I want to encourage you to be informed. It's very important because we play a very important role. And you see that throughout the discussion, I'm going to emphasize the concept of patient engagement. Patient engagement as an organization, our mission is to educate and advocate and promote patient engagement. And what does that mean? Well, we want to make certain that we include the incorporation of patient preferences in scientific research. We want to make certain that patient priorities can be integrated with science, and that can be done through a number of ways, which we're certainly going to touch upon this afternoon. You know, innovations in biologics, medical devices, and patient-reported outcomes, all of those are going to lead to a better quality of life for patients. So again, it is that perspective that I will bring to the discussion today. And I look forward to joining my colleagues and yourself and having a spirit and insightful discussion. I'll turn it back over to you, Jeff, and thank you so much.
Thank you, Richard, and really wonderful to have the patient perspective represented here. It's so important, and we'll come back to that, of course. I want to give Candace Nordy a chance to introduce herself.
Thank you. Good morning. Thank you, PMC, for hosting this webinar on this important topic. I represent Sloan Partners, which is North America's leading life sciences and healthcare executive search firm, and I serve as their Executive Director of Diversity, Equity, and Inclusion. I believe that Sloan is really at the forefront in leading change in the industry by using their platform to model effective diversity recruitment practices and increasing the pipeline through our Envision Mentorship Program. Our Envision Mentorship Program is really about helping Black and Latinx students navigate the healthcare and life sciences industry. I was an educator for almost 20 years before joining Sloan Partners, and I really think that a lot of the pipeline talent issues is not a lack of talent, it's a lack of access, a lack of understanding, and a lack of information on how to navigate the industry. I'm honored also in my role to spend my days working with companies to support them on their DEI initiatives and goals. I think we're starting to learn that these issues are systemic, they're structural, and they're going to take really collaborative and ongoing support. And so I bring that lens today. I'm excited to talk with the other panelists about how we can really make change.
Thanks so much, Candace. So this has been touched on a few times already in your opening remarks, and the diversity of the workforce in personalized medicine. It came up in the first panel as well, where it was clear that the best research can only take place with the most diverse research community, and having the researchers look like the participants, as well as the providers looking like participants, could really enhance the engagement. So I'd like to start off this session with the question around creating that pipeline that you referred to. Can we go all the way back to high schools and colleges, undergraduate education? I know Eli has mentioned the medical school education, but the pipeline starts somewhere. And I'm just wondering if all of you could give a perspective on what we need to do to affect the change, Candace, that you mentioned in your opening remarks, to encourage and excite and the most underrepresented groups from being part of the research community that you all represent, or the patient community that Richard represents, or the provider community that Eli represents. Could you all comment on how we create that pipeline?
I'd love to kick us off. Like I said, I was an educator in the K-12 setting for almost 20 years, and I ran a school that had a STEM lab, thought I knew everything about STEM, and then joined this industry and realized that I didn't know as much about STEM as I thought. And so I think we need to partner with communities and schools. We need to support teachers. Teachers are busy, but they want their students to pursue science careers. I really think also it feels scary to pursue science. It feels scary to pursue math. We have to help families understand that there's a whole world of opportunity out there if they will persist through STEM. And I, through Envision, often tell people that we do need more Black and brown doctors, but there are so many careers in life sciences that are making big decisions, and we need to tell people of color about those jobs.
So I think it's an important point that we need to ensure that the whole entirety of the life science workforce, not just the doctors and nurses, et cetera, are represented by people of color and diversity, and making sure that the workforce of tomorrow knows that there are many opportunities for them in the life sciences. It's not only being a doctor or a researcher.
Yes, and one more quick comment. When I meet with students,
yeah, sure,
they have a sigh of relief when I tell them that. Like they always say, I'm pre-med, I'm pre-med, I'm pre-med. And obviously, as Eli mentioned, everyone's not getting into medical school. So we need to help them understand that there are other career paths that they can follow.
Eli, do you want to make a comment on this?
Yes. The point I think that has already been made is, if we are going to end up with a diverse healthcare workforce, and for that matter, scientific enterprise, we are going to have to start at the level of probably high school, if not earlier. And I can comment briefly about what is transpiring in that arena with an eye towards increasing, hopefully, the number of applicants to medical school. What happens at that stage, or perhaps we should speak later on about what happens in college, first of all, and then what happens during the application process. We can perhaps defer that for later. But I would say that for now, there's a growing number of programs that dedicate themselves to what I would describe as after-school mentoring of disadvantaged middle or high school students, with an eye towards stimulating their interest, informing them about the workings of the system and what will be required once they graduate college, all with an eye towards enhancing the appeal of medical education to individuals at the middle and high school level. There is a growing number of those programs that I think originally were stimulated by a program at Southern Illinois University, but have since branched out to Ivy League schools and to many other medical schools all around the country. So while you may or may not be aware of those programs because they transpire in the background and physicians for the most part may not even know that they exist, they do exist. And it's at least a portion of a global effort to enhance the interest of high school and middle school students in the possibility of applying to medical school, and in so doing, diversify the healthcare workforce.
Thanks for that. One of the things you mentioned, I want to come back to maybe towards the end of this session, but the whole concept of mentorship, which in some cases is strategic, in some organizations, and in other cases it's stochastic. And I wonder if there's a role for the PMC to organize mentorship programs that could actually permeate through down to high schools and others, given its membership is so eclectic and diverse, and probably has diverse in terms of stakeholders and probably diverse in terms of individuals that could really play a role. So let's hopefully come back to that. Richard, I'm wondering if you have a lens on sort of developing the pipeline from a patient perspective.
Absolutely. And again, my vision's a little bit broad. And from a patient perspective, let me say this. Part of the challenge I've had to deal with, many patients have to deal with, we always talk about we need to educate. And I believe that that's true. But one of the things that I've come to find out is that many times we need to educate healthcare providers. And in this case, I'm going to talk about the corporate structure. There's education that needs to take place within corporations also. I'm going to build on some of the things that Candace said. Number one, we need to have a commitment from the organization's leadership. That seems obvious, but if it's not a commitment, it's not going to happen at the highest levels. So if someone spends time doing the things to develop the type of environment, but there's no support from up top, when budgets get lean, that's going to be cut. That's not going to happen. And then the other thing that's important that it needs to happen, I want to emphasize this. We're not looking at affirmative action. What we're looking at is managing diversity. And that is something that needs to be integrated with the overall strategic plan of the organization. So if it's not, if this doesn't have commitment from the top, if it's not integrated into the strategic plan, so what does that mean? Well, when you hire these people of diverse backgrounds, what's their attrition rate? Is there work satisfaction? Is there satisfaction within the workplace? Do they have mentorships built in? Because for those of you that work in a corporate setting and you've got goals and objectives, if you have to spend an inordinate amount of time mentoring and you can't get to other things, what happens to you during your review? So I think that we need to take a look at the status quo. And what I'm talking about are the things that generally get articulated as institutional racism and things of that nature. But we're going to go beyond that and talk about, I think, what can be some ideas that can be very, very helpful, because what we're looking at is developing an organizational culture, developing those shared values and reinforcing outcomes. And this can only happen when we have that commitment from the levels at the top, right up to the president. And it simply has to be integrated into the strategic plan so that it can have the impact, and we can monitor the impact on all the relevant metrics that we have within an organization. Now, once we have that, then we have a place that is receptive and will, I think, be more aggressive in terms of pursuing not just people of color, but good people across the board. One of the things I want to emphasize is that I don't look at many of these issues as an add-on. It's part of doing good business. That's what diversity is. You can benefit from the whole range of ideas that are out here. And when we look at shared values, I think that there's a lot that can be brought to the table that many organizations are missing. I'll give it back to you, Jeff. I know I can go on for that about hours, but
No, that was great. And actually, to me, it sounds like you're speaking Christopher's language based on what he said in his opening about what AbbVie is doing. So maybe, do you want to elaborate on maybe taking a lead from Richard's remarks? What is the, it is coming from the top at AbbVie. Based on what you said, maybe you can just elaborate a little bit more on some of the ways you're thinking about the business decisions you even make in terms of whether you work with a partner or not, if they really adhere to AbbVie view of diversity or not.
Yeah, I mean, in many respects, it does start with the top. I think I've commended publicly and privately our senior leadership, immensely for the work that for the vision they've outlined, the resources they put behind it, and just the sheer commitment to it. And not only because it's a good business decision, it's just the right thing to do. And I think that more and more companies are certainly embracing this idea of corporate social responsibility and the role that we all play in the society. And for many folks within these companies, our lives are bigger than just the 9 to 5 and the time we spend within the walls of the organization. So for us, I mean, it's to really partner with other organizations that embrace those sort of cultural values that you embrace as a company. You want to be able to take pride in that. And so I think for us, actually expecting that from our partners is really, to be honest, it's a starting point. It's really around what can you effectively do in your sort of sphere of influence in order to invoke change. I think that Rick Gonzalez, our CEO, has been very public in stating that many of the issues that we've seen just from a social justice perspective are wrong, right? And he hasn't been shy about stating that. And I think that as part of that, it does, it almost creates a sort of self-imposed challenge of how are we addressing the issues within our own sort of span of control. Obviously, it gets no clearer than reflecting it in your own workforce. And then but then it creates challenging, oftentimes people are talking about purely just the recruitment of talent. I think even one of the bigger issues is not just recruitment, but the sort of inclusion or integration of that talent and the retention of that talent and creating somewhat of a level playing field when it comes to opportunities within an organization. Because you want to be able to sustain that level of change. Unfortunately, we've seen periods where there's been this heightened sense of awareness and commitment to recruit more diverse talent. But oftentimes it's not sustained over time because, many corporations are suffering from ADD, right? So it's whatever the most pressing problem or issue is at that time. And so, so for us, I mean, it's something that, that we're, it's all a journey. There's no destination. We want to be able to really embed it into the DNA of the company. And so that it is sustained and it becomes who we are. It's not just an act or an initiative. It becomes the way we do business. And for that, it does come in the form of mentorship programs, which I participate in a number of them. It does come in the ability to really create a safe space for people to voice their concerns. And it certainly becomes a place where we want to be able to address those issues that the other panelists alluded to earlier, where we are creating that pipeline of talent very early on. And so, so these are all things that I know me and many of my colleagues have been actively addressing. It's things that it's not just lip service, but I'm probably a bit more vocal about it than many of my other colleagues are. And so, and to me, that's a good thing, right? I mean, because it's not that we're just using it as a sort of billboard material, but it really is in the fabric of the organization.
Yeah, I love that concept of the fabric of the organization and making it part of the strategy up front as opposed to an add-on, which I think was Richard's point. I want to make sure in the remaining time we touch on some of the issues around access. This session is meant to look at workforce, but also maybe access. And one of the things that comes up whenever there is new technologies being brought to healthcare, they often are expensive. They lead to a divide rather than a coalescence. And in personalized medicine, I think there's a real risk of creating a personalized medicine divide with expensive genetic and genomic testing or digital health technologies. I'm just wondering, how do we really close this gap and ensure that rural, inner city, underrepresented, lower socioeconomic groups have the access they need to fully benefit from personalized medicine? And I'm wondering if any of you have some thoughts about what's to be done going forward.
I can certainly start. I think there's been, I remember several years back, I was at the Congressional Black Caucus, their annual legislative conference that they have in DC. And I was there talking about this issue around diversity in clinical trials. And there was an audience of members from the National Medical Association, which is the African American version of the AMA, right? And I just thought it was interesting because everyone was looking at me like, you're a pharma company. Why are you here talking to us about this issue? And more importantly, I'm not an MD, I'm a data guy. So they're really trying to understand this sort of hook of why I'm speaking to them about this. But really the angle at that time, honestly, was that what I could see and what the data was showing, that there was so many social determinants that were affecting our ability to have a diverse sort of participant population in clinical trials, and it was creating problems, right? But I think and rather than talking at them, I felt like it was much more of a dialogue. But what I learned from that experience from them actually was just the sheer level of commitment that they had to, as investigators, commit themselves to, and the lack of resources that they had. So some of my key takeaways from that discussion were around, in addition to the lack of trust, which I know was mentioned in the last panel, there was a lack of information, there's a lack of awareness, and there's a lack of resources. So there's just plenty of lacks when it comes to the sheer effort of getting diversity in clinical trials. But then you move forward and you have this sort of, you have the pandemic, and then you have this explosion of this concept, which has been around for a number of years, this idea of using virtual or decentralized trials as a mechanism to reach rural and what would be otherwise underrepresented populations in clinical research. And so what I think is that, to your point around the digital divide and how it's actively addressed, I think that we're going to have to use, first of all, data to better understand who and where these patients are and the prevalence of many of these conditions, and who we should be recruiting. And what I say by that, what I mean by that is that it's, I think people have mistakenly said, okay, we'll say African Americans, 13% of the US population. We should see 13% in every clinical trial of, it should be African American participants, right? And that logic doesn't make a lot of sense to me, because I'm like, in every clinical condition, you don't have that level of prevalence in the, we'll say, African American community for those conditions. So what the power of the data allows us to do is to understand those prevalence and incidence rates of those very targeted populations and try to align ourselves as best we can to those numbers. But more importantly, we're better utilizing geospatial data to be able to shift, where we focus those clinical sites are. And, and I'm going to loop this back even to this issue around training and development. Part of the issue that we've had with, even when it comes to investigators or even this pipeline or STEM talent and all these things we talked about, is we're still taking very traditional sort of recruiting approaches to to recruiting talent as well as recruiting participants. And I think that what the challenge for us is to really challenge our own thinking, challenge those conventional approaches, and really and to go where people are, and create mechanisms where we can do that. And I think a lot of that is through data and digital technologies.
Thanks, Christopher. We're coming close to the end, so I really want to give everybody a chance to also comment on this. So Richard, and then maybe Eli, and then Candace.
Okay, I'll make a few brief comments. Let me say this: one of the speakers early, Dr. Bonham, I believe, made reference to NIH. Well, I'm also working with a project called the Kidney Precision Medicine Project under NIDDK, and very similar to many of the areas precision medicine project. Now, we've got a community engagement committee on there. And as an organization, the American Association of Kidney Patients, we have worked with them collaboratively to promote this, again, under the caption of educating patients. That includes talking about clinical trials, the need for it. Why should you participate? Why is it important to you? Again, we're talking about education. And to Chris's point, we're reaching patients throughout the country. We provide the largest gathering, now it's virtual, in the country on the topic, and we invite these individuals out to speak. As a matter of fact, if you look on your social media, we promoted this event very heavily, so we probably have some patients looking in. They're having a Facebook session this afternoon to talk about that particular project. And we geared our social media to reach out to a number of patients. It's on Facebook. They can go and take a look at it or look at the recording. So we make a very, very aggressive attempt to educate the patients. And at the same time, we're working with many, many organizations, such as Chris's organizations, to help them have access to the patient population that we have. So that's one strategy I think that all of the companies can employ, which is to try to reach out and develop relationships with organizations within the different areas of illness, so that they can have a ready-made population with which they can engage with before there's a crisis situation. Turn it back to you, Jeff.
Okay, thank you. Eli?
I gather we're getting very close to the conclusion of the program, so I will be brief. I think the fundamental question you posed was, how do we address the relative shortage of healthcare attention and providers in areas of the country that tend to be deprived? And of course, creating a more diverse healthcare force helps, but then you've got to get those providers to rural and underserved parts of the nation. As you know, HRSA, one of the governmental agencies, is hard at work to make that happen through a variety of financial mechanisms, making it attractive for some individuals who struggle with loans and the like to, in fact, assume responsibility in some of these provider-deprived parts of the nation. And of course, the telemedicine initiative is a great move in that direction, although, as was pointed out, the digital divide cuts into that in a very significant way, which makes it difficult. So we're doing some things, but the challenge is still substantial. The limitations are real, and time probably precludes us from doing it any more justice. So I will, at this point, hand it back to you, Jeff, and perhaps we can bring this to a closure at a reasonable time.
Thank you, Eli. Candace, your thoughts?
I'll close by just saying that I agree with the panelists that mentioned that we have to have out-of-box solutions. We can't do traditional recruiting, traditional clinical trials. As an educator, we were told that we can't teach remotely. Many companies were told that they couldn't work remotely, and on a dime and a day, we all pivoted and we did that. And also with us coming with the COVID vaccination, we put all of our time, talent, and treasure into making that happen. And we can do the same thing around advancing these issues in our companies.
Thank you. We're a little bit over time, but I thought I'd just make a couple of just quick points on the workforce piece. We heard around some very impassioned pleas to create the pipeline from the very beginning, beginning to educate our high school students about the diverse opportunities in the sciences for them to play roles, as well as from the top, from the C-suite of companies and other organizations, to make it a strategic imperative to have diversity of workforce as part of the fabric of these, whether it's public, private, or something else. And on the divide piece, we talked about the patient at the center and being informed and educated, and the amazing work that Richard's group is doing to help patients with kidney disease understand their opportunities to do outreach, and also to really bring healthcare providers to rural communities as much as possible to close that divide. Again, I did not do significant justice to everything all of you have said. Insights have been amazing. I want to thank you, and thank you for a wonderful panel. Again, I apologize for being over a minute or two, but I want to turn it now back to Ed Abrams to close.
Thank you. Can you see me?
You're not, your video, now we can, yes.
I first want to, this has been a great discussion, and I want to thank Jeff for his willingness to moderate it. I want to thank the panelists for sharing their ideas and views with us, which we were going to think about and turn into a project that we think, that we hope makes sense. And I want to say in conclusion, and perhaps to channel Jane Delgado, who noted that we can't move forward on these issues without good science. And good science in turn depends upon good data and widespread diversity. And that essentially is the principle of personalized medicine. So I'm optimistic that PMC can contribute, and I look forward to working with all of the panelists, with Jeff, and with our members, many of which participated or tuned into this Zoominar. We have our work cut out for us. We're going to do our best. So thank you for your time and attention this morning. We look forward to the next chapter.